Hi, everyone. Thank you for joining us today as we explore updates in spinal bulbar muscular atrophy. And it is my pleasure to introduce Dr. Christopher Grunseich. Dr. Grunseich, go ahead.
Hi, Veronica. Thank you so much for inviting me here to give this talk and discussion on spinal and bulbar muscular atrophy. It's a pleasure to speak with everyone today on this topic, and I look forward to answering your questions at the end of the session. Next slide. The goals of this program are to recognize the symptoms of spinal and bulbar muscular atrophy, understand the importance of using genetic testing for the diagnosis, to identify the best practices for the management of patients diagnosed with SBMA, and to incorporate recent advances from clinical studies into patient care, and to locate additional tools and resources that may be useful for physicians in the community and for patients. Next slide. Our agenda for today's talk will include an overview of the disease, the genetic etiology of spinal and bulbar muscular atrophy, some of the clinical manifestations that you can anticipate encountering both in the early stages of the disease and as the disease progresses. We're going to talk about how the diagnosis is made, how patients with SBMA are managed, some of the ongoing clinical research in the field, and resources that would be useful for you as a clinician in managing a patient with SBMA. So an overview of SBMA, the SBMA is a disease that affects males. It is an androgen-dependent disease, and it is caused by a CAG repeat expansion in the androgen receptor gene. Typically, healthy individuals have repeats in this part of the gene, but when that repeat number exceeds 37 CAGs, that's when it becomes pathogenic and results in SBMA. And some of the hallmark features of the disease include loss of motor neurons, muscle weakness. There are other non-neuromuscular manifestations of the disease that we'll discuss in a little bit. As far as the epidemiology is concerned, the prevalence of the disease does vary depending on what part of the globe that you look at. But a rough estimate is that the number of individuals affected is about 1 in 40,000. And what's very interesting as of late is a recent study that was done using whole genome sequencing that identified that the prevalence of the disease may be as high as 1 in 7,000 males, and that it's underdiagnosed, underappreciated. And we really need to think carefully as a community as to how we can diagnose more patients who should be presenting with symptoms given this reported incidence of 1 in 7,000 males. The onset and prognosis of the disease, the onset typically occurs around the mid-40s, and the disease progresses slowly. If we were to quantify the rate of that disease progression, it would amount to about a 2% change in muscle strength per year. Some patients may become dependent on a wheelchair, and that if that does it is the case for patients, usually that's about 20 to 30 years after the onset of disease. Though some patients will have a reduction in life expectancy, majority of patients do have a normal life expectancy. Next slide. This slide is showing an image on the left of a PCR reaction. A PCR reaction can be used to make the diagnosis, and this is showing PCR reaction from blood samples from 2 different families in which there was evidence of SBMA. And the males are shown as squares and females are shown as circles. And if the individual is affected, if the male individual is affected, the entire square is shaded in. Females are carriers. Females can have 1 normal copy and potentially 1 affected abnormal copy. And what this gel is showing is the PCR from the blood targeting the androgen receptor gene. And we know that if someone has a normal unexpanded copy, when that PCR product is made, the gel product migrates lower on the gel. So what you could see here in the male, the second male from the left, on the left side of the gel, you could see that that band is running lower compared to the band just above it that's underneath the dark shaded square. So the male individual who's affected has an expansion of the androgen receptor gene, and that expansion is a CAG repeat expansion that codes for glutamine. So the androgen receptor protein has additional glutamine amino acids. And this test is very specific and sensitive for the diagnosis of SBMA. Again, when that repeat number exceeds 37, we know that's when someone will manifest with symptoms of the disease. And again, what this gel also shows is that females, again, and that's the circle here in the diagram, the circles that have the dot in the middle indicate that that female is a carrier, and she has both a normal copy that's the bottom of that lane, and then the expanded copy of the androgen receptor is shown in the band just above the normal copy. If you look at the right side of the slide here, this shows the inheritance pattern. Female carriers will inherit the affected X from their fathers who are affected. So the the daughters of an affected male are called obligate carriers because they could only receive that expanded copy of the androgen receptor from their affected fathers. A carrier female can manifest with some symptoms, but fortunately, usually they're not manifesting with weakness. They will experience sometimes numbness, cramping, fatigue, but usually never weakness. A carrier female has about a 50% chance of passing on that affected copy of the androgen receptor gene to their children. Both males would then have SBMA and other females who would then be carriers. Next slide. We know that there is a relationship between the size of the CAG repeat expansion and the average age at which a patient manifests with weakness. This graph on the left side shows a Kaplan-Meier analysis, of course, many patients with SBMA, lumping those patients into those who have a CAG repeat equal or greater than 47, and those patients on the right side who have a CAG repeat length of less than 47. And what you can see is that the patients who have a larger CAG repeat, on average, tend to have an earlier age at which they manifest with weakness. Now, although that age at which they present with weakness can be early in patients with a larger repeat, it doesn't necessarily mean that their disease is going to advance any faster than those who have a shorter repeat. And that's shown here in this study that was done evaluating changes in disease progression, basically the time that it took a patient to go from manifesting with muscle weakness to requiring the use of a handrail. And what you could see is that that amount of time doesn't change for patients who have CAG repeat lengths of less than 47 compared to those who have repeat lengths of greater than or equal to 47. So just to recap, a larger CAG repeat means an earlier age of onset on average, but doesn't necessarily affect the speed at which the disease progresses. Okay, next slide. This slide is showing some of the main clinical manifestations of the disease. We know that SBMA is a neuromuscular disorder. It will result in loss of the motor neurons both within the brainstem and in the spinal cord, and that results in weakness to those muscles that are innervated by those motor neurons. So weakness of the bulbar muscles and weakness of the limb muscles, both the proximal muscles in the upper arms and legs and the distal muscles in the hands and feet. Other manifestations of the disease can include androgen insensitivity. This can present with gynecomastia, breast enlargement, infertility, testicular atrophy. Patients can also have other metabolic symptoms such as non-alcoholic fatty liver disease, insulin resistance, hyperlipidemia, increased triglycerides. Some of the laboratory tests can show elevated creatine kinase, which is typically 5 to 6 times above the normal reference range. Patients also can present with sensory neuropathy, and it's important to remember that because that can help us in distinguishing SBMA from other neuromuscular conditions. And the sensory neuropathy can also be one of the early manifestations of the disease. Some patients can have electrical arrhythmias in the heart conductance pattern, and one of those arrhythmias includes Brugada syndrome. Many of our patients in the US do not have Brugada syndrome, but it's important to screen for that to ensure that there are no changes on ECG testing of the heart's electrical activity. Next slide. This slide discusses some of the initial symptoms that patients can present with. Usually the symptoms will arise between the ages of 35 to 40, but there are extremes in this situation. Sometimes patients can manifest with symptoms as early as 18, and we have seen patients manifest with weakness in their 60s. Some of the initial symptoms include muscle cramping, tremor, weakness, as we discussed, both proximally in the upper arms and legs and distally in the hands. And this can show up as difficulty walking stairs or walking long distances. Patients can sometimes present initially with bulbar weakness, and this can manifest as difficulty with speech, swallowing, choking, managing saliva. Patients can also manifest initially with sensory neuropathy. This is usually in a length-dependent distribution, so patients will have loss of sensation initially in their toes or their fingers, and there also may be evidence of androgen insensitivity. Many of our patients will report gynecomastia even before the onset of weakness, so it's important to keep that in mind. And then other features of androgen sensitivity can be the oligospermia and erectile dysfunction. Next slide. Some of the other initial observations that can be made include, of course, the effect on strength and muscle function. Patients can be detected to have decreased muscle strength, both on manual muscle testing exam and also specialized equipment that could be used to measure muscle force will show a reduction. Sometimes it can be reduced 50% compared to healthy controls, if not more. And the weakness asymmetry is common, and sometimes weakness can manifest initially on the dominant side compared to the non-dominant side. Some of the other initial observations can include the changes on electrophysiology, the nerve conduction studies, and EMG. Almost all patients will present with some sensory nerve conduction deficits. So the central nerve amplitudes can be reduced. Other sensory nerves can also have diminished amplitudes, such as the ulnar, radial, and median nerves. There may be also deficits in the motor nerve conductions, and this can be detected in the median nerves and the peroneal nerves. And the motor unit number estimation by electromyographer can detect a reduction about half compared to healthy individual values. Patients may also report deficits on activities of daily living, such as walking, handwriting, falling, swallowing difficulties, and speech troubles. Patients will also have changes on their quality of life, particularly the physical component outcome measures on those quality of life scales will be impacted. And patients, as we mentioned before, can have symptomatic erectile dysfunction. Next slide. This slide shows some of the facial weakness that can be detected in patients with SBMA. Patients, as a result of the weakness, can have difficulty moving muscles in the face, the muscles in the cheek, the buccal muscles, the orbicularis oris can be affected, the orbicularis oculi, and that can affect saliva control, predisposition to choking, articulation, and dysarthria. And this video does an excellent job in showing how the muscle in the tongue can also be affected. We can see atrophic changes in the tongue and also fibrillations, a sign that there's denervation, that the nerve going to the muscle is being impacted, and there's the fibrillation of the muscle as a consequence. So can we start that video here? Great. So here again, you can see that there's atrophy of the tongue. And also we can see fasciculations in the muscles around the face. You could see the chin fasciculations. And you could also, when the patient had their tongue open, there are fibrillations within the tongue muscle. So these are important observations to make when you're evaluating a patient whom you consider may have SBMA. Next slide. To assess the predisposition for dysphagia, it may be useful to get a video swallow test, a video fluorography. And this test is done with the patient's swallowing contrast material. And what can be detected is retention of that contrast material at the back of the tongue in the postcricoid region, Also, during the video portion, there will be a slow movement of the contrast material down the esophagus. And it's important to look for this, especially if patients are complaining of choking, because changes in how they're eating and different modifications they can make when chewing can reduce the risk of aspiration and pneumonia. So these are important aspects of the disease to consider when evaluating a patient with SBMA. Next slide. We know that the disease progresses slowly, and there are a stepwise series of changes in symptoms that have been observed across many different natural history studies of the disease. At early ages in the 30s, typically patients can present with tremor and weakness. If it does manifest in the 40s, can go on to produce other symptoms in patients who then have decline in their motor and strength function. Patients can go on to be dependent on handrails, other mobility assisted devices, and sometimes several years after the onset of muscle weakness, patients can have dysarthria and then dysphagia. Though I will say that this particular pattern can fluctuate and be dependent on the patient's pattern of weakness and whether or not that patient has predominantly more bulbar onset compared to limb onset. But patients can go on to use devices such as canes and wheelchairs for their mobility. And it's really important, as we mentioned, to be aware of the choking risk because this can predispose to pneumonia and hospitalization. Next slide. We know also that patients with SBMA are predisposed to having changes in metabolic function. This slide is showing the evidence of insulin resistance that is detected in several studies of the disease by this HOMA-IR measure. The HOMA-IR is a ratio of the patient's glucose over their serum insulin level. And the higher that HOMA-IR measurement is, the more evidence of insulin resistance is present. And what has been shown in several studies is that there's a relationship between the amount of insulin resistance and muscle strength and muscle function, as shown here by the ALS functional rating scale. So patients who had more insulin resistance in this study were not performing as well on the ALS functional rating scale. And it's important to be aware of this because patients can be screened to make sure that they're not having elevations in serum glucose. If they do become diabetic, that they're appropriately managed by an endocrinologist or an internist for taking care of this important symptom. Next slide. The diagnosis of SBMA can be challenging, and there can be a prolonged time period that passes by before patients have a diagnosis that's made. And this can be a challenge, both, of course, for the patient, for the family, and it also can be very costly for the hospital and the medical care system in general. And it's important that we try to do our best in determining whether or not patients meet the criteria for warranting genetic testing. So it's important to involve a genetic counselor if there are other family members involved. Sometimes patients will present without a family history, but if there are other affected individuals in the family, it's important to involve a genetic counselor to advise on the importance of testing for SBMA in this circumstance. Patients with SBMA, should also be considered if the laboratory blood work, is suggestive of the diagnosis. So, for instance, if the serum creatine kinase is elevated 2 to 5 times above the upper limit of normal, then it would be important to consider SBMA. Likewise, if there's evidence of denervation on the EMG testing, if the nerve conduction study testing should also show changes on the sensory nerve action potentials, then that's really important in shifting the diagnostician to consider SBMA. And the genetic testing is definitive. It's very clear. It's just a simple test on a tube of blood, extracting the DNA. It can be done on saliva as well. And the test will look at the CEG repeat expansion in the androgen receptor gene. And again, if that repeat is over 37, then that is diagnostic for the condition. Next slide. In the differential diagnosis of SBMA, there are other neuromuscular diseases that can be considered, other hereditary motor neuron diseases, such as spinal muscular atrophy with adult onset. SMA is usually a disease that affects children, but we can see presentation initially as adults. Adrenoleukodystrophy and hexosaminidase A deficiency can also be considered. Other forms of motor neuron disease that are acquired are also in the differential, just sporadic ALS, poliomyelitis, not as common right now with vaccines, and myopathies, including FSHD, oculopharyngeal muscular dystrophy, mitochondrial disorders. Other diseases that affect the muscle should also be considered. Many patients with SBMA will have a lot of muscle complaints, muscle cramping, muscle weakness, and other diseases that primarily affect the muscle are also included in the differential diagnosis. Other neuropathies should also be considered, whether they're hereditary, such as Charcot-Marie-Tooth disease, or acquired neuropathies are also in the differential and should be considered. And what's really interesting is the differential of myasthenia gravis. Patients with SBMA will have a lot of fatigue, and myasthenia patients will also have a lot of fatigability in their presentation. And I have seen many patients who are thought to have myasthenia who actually do have SBMA, and the nerve conduction studies are really important in guiding the practitioner, evidence of denervation with SBMA, or evidence of this sensory involvement with SBMA, but not myasthenia. Next slide. The care of a patient with SBMA definitely benefits with a multidisciplinary approach. It's important for a neurologist to be involved, of course, in establishing the diagnosis and in coordinating the care from all of the specialists who should be involved. So I'll just start at the 2 o'clock position here with the neurologist and go counterclockwise. The speech therapist plays a really important role in identifying any deficits in communication and dysarthria that could be improved. There are different prostheses that can be placed into the mouth to improve articulation, and that can be done together with a speech therapist. Also, the speech therapist, together with the physical therapist, can prescribe exercises targeting those regions of the body that are most impacted in the disease. And we have seen patients improve with exercise, and that should be done together with a physical therapist to assess where the patient's weakness is and which types of exercises would be best in targeting those deficits. A pulmonologist can be very important, especially for those patients who have respiratory symptoms. Usually, if patients do need assistance, it's because of challenges with sleep, sleep apnea, managing secretions, and guidance on managing all of those symptoms could be done together with a pulmonologist. An endocrinologist could be very helpful for treating the metabolic changes, as we discussed, the insulin resistance. Patients may also have other changes on their endocrinological assessments, such as hyperlipidemia, that could also be managed together with an endocrinologist. Psychologists can be very important, not only for the patient, but for the other caregivers who can also be really drained in taking care and helping a patient and a family with SBMA. A dietitian can be very useful depending on patients who have difficulty swallowing, if there needs to be a change in the consistency of the food or a change in the caloric intake with supplementation so that patients can ensure that they're getting the appropriate caloric intake. This could be done together with a dietitian. An occupational therapist can help patients tremendously, especially those patients who are having weakness in their hands, to identify different devices that can be used to improve mobility and hand and arm function. Social workers can be very useful to identify the resources that are available financially and to identify how patients can maximize the benefits that are due to them when they're diagnosed with this disease. I'm a cardiologist, again, for monitoring for arrhythmias. Again, I want to say that we don't detect that frequently in SBMA, but it is important to be aware of this potential complication. Next slide. The clinical management of SBMA, right now, we do not have a drug to treat the condition. We don't have any disease-modifying drugs, but there are many on the horizon that look promising. Many of the agents that have been considered so far in studies have tried to target the androgen receptor function. You could see the androgen receptor here is abbreviated AR in those red rectangles. And so drugs that have tried to block the activation of the androgen receptor have been tested before in studies, such as leuprorelin. That's a drug that reduces the amount of testosterone in the body. Or the drugs that try to reduce the body's production of androgen receptor itself are under development. These are antisense oligonucleotides to try to antagonize the normal function of AR to reduce that toxicity to the muscle and to the spinal cord. Other approaches include ways to try to improve the clearance of the androgen receptor by activating pathways that we know move the androgen receptor into the garbage disposal system of the cell, the ubiquitin proteasome system, abbreviated the UPS here. So there are a few different strategies for doing this. Some of them have been tested in studies, and some of them have shown promise, but for one reason or another, we're not able to move forward with some of those agents that have been tested previously. But there are others that are under development, and we hope that one of them in the near future will prove effective in impacting the disease progression, improving our patients' quality of life. Next slide. There are studies that are underway right now, and it's important to highlight a few of them. The first one here, AJ201, is a study of an analog of curcumin. This is just completed the phase 1/2A stage in a population of SBMA patients, and we're waiting within the next few months, hopefully, to have results of this study, primarily looking at safety in SBMA patients, looking at the pharmacokinetics, and hopefully, if those results are promising, there will be advancement of this agent into the next phase of study to evaluate for clinical efficacy. There is a study of clenbuterol that's underway. This clenbuterol is a beta-2 agonist that activates the phospho-AKT that modulates the clearance of androgen receptor from tissues. And this is a phase 2 placebo-controlled study of patients that's being done in Italy right now, and we hope to have those results in the near future. And it's also very exciting that there is a study with this androgen receptor modulator. It's an allosteric modulator of the androgen receptor, so the drug binds directly to the androgen receptor protein. And right now, this is being evaluated in a study in several countries, including Denmark, Italy, South Korea, and the United Kingdom. And that the study should give us a lot of insight into whether or not this approach of modulating AR function is impactful on slowing the disease progression. And the name of that study is Pioneer KD. Next slide. The registry for SBMA patients is very important. This registry is set up by a nonprofit group, the Sanford Chords, and this was set up by the Kennedy's Disease Association and collaborators to help facilitate patient enrollment in future trials. This is such an important point to identify where patients are across the globe who are interested in participating in studies. So I would encourage all the practitioners diagnosing patients with SBMA to encourage them to look at this resource for a few reasons, because the data that's generated in this registry can be used by those who are qualified to do research on the disease to understand how the disease progresses over time. And then this registry can also be used to facilitate enrollment into future clinical trials. Our group has used this for the recent study that we participated in, and it proved very helpful. I think it's an important resource, not only for SBMA, but for other diseases that you're hoping to enroll patients into future clinical trials. Next slide. Other resources include, I attach a publication here by Dr. Perdat's group in France. They recently published a consensus diagnostic and management recommendation. And this is a very useful set of guidelines if you'd like to delve into more literature on what the diagnostic and management recommendations are. In addition to what we discussed today, I would encourage you to look at this document that was published in the OrphanNet Journal of Rare Diseases. And it has very useful recommendations that you can take to, if you're a patient and you want to bring this to your neurologist, I would encourage you to do so. Or if you're a neurologist and taking care of a patient with SBMA, I would encourage you to look at this document. The Kennedy's Disease Association, the KDA, is an excellent resource for patients, families, and researchers. The KDA funds research on the disease, and they also act as a support group for patients and families to learn more about the disease, and they hold meetings, annual meetings and other events throughout the year. The MDA, of course, if you'd like to find more information on SBMA and other neuromuscular diseases, I would encourage you to look there for more information.